have you in Cairo on your presentation, and we look forward to it.
Thank you, Mohamed, and thank you very much to the organizers for giving me the opportunity to be back to Cairo another time. And let's say that what I'm going to share with you is something that apparently is well known, because it's the phenomenon so-called metabolic memory or legacy effect of hyperglycemia. This is something that we learned many years ago. Many years ago, you see this review was published in 2009, so 16 years ago. The metabolic memory was already emerged from several years, and it was defined as the epidemiological and prospective data supporting a long-term influence of early metabolic control on clinical outcomes. Meaning that in practice, what happens in diabetes at diagnosis in terms of glycemic control can influence the long-term development of complications. We learned this from first of all, from the DCCT study, which everybody knows was the study performed in type 1 diabetes, showing that optimal glycemic control can prevent the complications. And then when this study was stopped because the effect of glycemic control was so clear, the EDIC post-survey started, and the two groups of patients, of course, were put on the same intensive therapy. They had over time, for years, the same A1C, but after years, even having the same A1C, people who had a strict metabolic control from the beginning still were showing an advantage in terms of protection against any kind of complications, including cardiovascular ones. The same was then demonstrated in UK-PDS. Again, type 2 diabetes, good glycemic control from the beginning, improved the prognosis for complications, and this kind of advantages was shown even after 10 years in the follow-up of the study. So in other words, we have evidence that what we do at the beginning is very important, because if we control intensively the glycemia at the best level, we can condition the long-term development of complications. And also, this has been supposed to be the reason why in UK-PDS we were able to show an advantage in strict glycemic control on complication development, but in the well-known trials like VADT, ACCORD, and ADVANCE, this was not demonstrated. Because in these trials, started very late in the history of diabetes, around 10 years after, the metabolic memory was supposed to be already there. And so the possibility of improving the prognosis for complications, just controlling hyperglycemia, was highly reduced. But what is really surprising is that in type 1 diabetes, we have a long-term follow-up. And even after 30 years, 30 years of follow-up of the DCCT, still an advantage of people in terms of reduction of complications in people who were treated intensive from the beginning, this advantage is still there. And in the case of type 2 diabetes, it has been published that in this study, if you reduce a 1% A1C within 1 year from the diagnosis, you see the prognosis in the long term is following the green line. If you reduce 1% after 5 years, then you see what happens in blue line. If you reduce the 1% after 10 years, there you see the prognosis for the complications is demonstrated in the red line. So meaning that as early as possible to improve, let's say, to almost normalize the glycemic control, better is the long-term prognosis. And finally, this is the last clear, strong recommendation, strong evidence that what we do at the beginning is still there in type 2 diabetes after 24 years. In this study published last year in Lancet, you see that after 24 years, who was treated in an intensive way from the beginning, still is showing an advantage in terms of huge reduction for the risk of future complications. So no doubt, it's really mandatory to reduce hyperglycemia as soon as possible and possibly at the beginning of the disease, at the diagnosis, in order to improve the long-term risk for any kind of complications. Why I'm spending few minutes about the pathophysiology of the metabolic memory? Because now we have, this is why I'm telling you the metabolic memory is back, because we have a new horizon how to afford this phenomenon. You know, until now, the only strategy has been considered to lower hyperglycemia, to normalize glycemia as soon as possible, but now we have other possibilities that I'm going to show you, but for this, in order to understand, we need a little bit of, to understand the pathophysiology behind the metabolic memory. It's well known that according to the studies of Michael Brownlee and honestly also of my group, the diabetic complications are related to an overgeneration of free radicals at the mitochondrial level induced by hyperglycemia. You see, this is the key phenomenon leading to the appearance of the complications. But what about this aspect related to metabolic memory? You were the first proposing this kind of a new design in order to explore the effect of metabolic memory on oxidative stress generation. You were culturing some endothelial cells for 3 weeks in continuous normal glucose, in high continuous glucose, and in high glucose for 2 weeks, and then the cells were switched for 1 week to normal glucose in order to mimic the possible effect on metabolic memory. And we found briefly, I don't want more you go in details, that compared to constant high glucose, the metabolic memory was having the same effect, meaning that switching or not the cells from high glucose to normal glucose, after exposing them for 2 weeks to high glucose and then switching to normal glucose, did not influence the generation of oxidative stress. So meaning that after 2 weeks, something happened in the cells that was favoring a continuous overgeneration of oxidative stress. And particularly, this has been confirmed when we used several different antioxidants, because the hypothesis was, okay, oxidative stress is involved, what about the use of antioxidants? But the best antioxidant was working very well was an antioxidant which worked specifically at the mitochondrial level. So identifying mitochondria as the key player also in the metabolic memory for the development of this situation. And so, another pathway which were explored was that during all these activations or different pathways, you see also ages are formed. And it has been reported that age also are favoring, because they linked to mitochondrial proteins, and they favor the overgeneration of superoxide proteins, not only in the kidney, but also in other tissues. And the glycation of mitochondria is not neutral. On the contrary, when the glycation of mitochondria is induced, you have an overgeneration of a superoxide which is complementary to what is induced by hyperglycemia. So in other words, you have that hyperglycemia induces overgeneration of superoxide at the mitochondrial level directly, but also through the glycation of a mitochondrial protein, which is a stable phenomenon, lasting for a long time. And so it is why we propose this vicious circle of metabolic memory, where the mitochondria can be considered the key player of this effect, because the next step is that this can produce some DNA alterations which can last for time. Why I just spent time to show you briefly the possibility that oxidative stress is a key player in the metabolic memory induced by hyperglycemia. You see, you know, probably it's less recognized, because in the last years we were learning a lot about SGLT2, but mainly clinically. Then we had several hypotheses to explain why SGLT2 are so good in reducing heart failure risk and protecting the kidney, but probably is less recognized that the SGLT2 receptor is a modulator of intracellular antioxidant defenses. In terms that when this receptor is activated, you have an increase of oxidative stress in the cells because the defense are down-regulated. Therefore, if you block the SGLT2 inhibitor with an SGLT2 inhibitor, you improve the antioxidant defenses of the cells. Why this is important? Because, look, in the UK, of course, in the DCCT headache, we had only insulin as treatment. But also in the UK PDS, you had only insulin, sulfonylureas, metformin. So no one of the new drugs like SGLT2 inhibitors or GLP-1 receptor agonists has been tested on what they can do on the metabolic memory. And now, then we were wondering what happens now with these new drugs. Particularly, do an early introduction of a SGLT2 inhibitor attenuate the legacy effect of hyperglycemia? We used the huge database of MD Annals. This is an Italian database which is collecting data from 2004. We are following some millions of people with either type 1 or type 2 diabetes. And we divided, we were following in this data, we were searching in this database people with the type 2 diabetes not having complications at the entry, no one complications. And we checked what happens if you introduce an SGLT2 inhibitor after 1 year from the diagnosis, or after 2 years, or after 3 years? First of all, we confirm the presence of the metabolic memory. So, no surprise. But what was really interesting to know, to find out, is that if you introduce an SGLT2 inhibitor within 2 years from the diagnosis, you avoid the appearance of the metabolic memory. Clinically, this is why 2 years and not 3. Probably there are some epigenetic changes in DNA that they require time, and after 2 years you cannot counteract. This is a possible hypothesis. But what is really important is the clinical impact of this. Because in the study, we showed that even in people not at the target of A1C, having an A1C higher than 8, when the SGLT2 was introduced within 2 years, the legacy effect of hyperglycemia was stopped. And this is the first evidence giving hope that metabolic memory can be prevented not only with the strict glycemic control, but also using a specific treatment. It is why, in the conclusion of this study, we suggest that this finding advocates a wider and earlier use of an SGLT2 inhibitor. Last year, 1 year later of our publication, this Chinese group published a very similar paper, but using, also checking the effect of a DPP4 and GLP-1 receptor agonists on the effect of inducing the metabolic memory. They had the possibility to look at a more huge database. I think nobody is surprised. When we speak about 1 million in Italy, usually you speak about 10 million of patients in China. So they had the opportunity to check also for the DPP4 and GLP-1 receptor agonists. They used our approach, you see here, meaning what happens if you introduce these drugs after 1 year, 2 years, or 3 years in people without complications at entry. And they found out that either SGLT2, which so confirming our data, but also GLP-1 receptor agonists can counteract the appearance of the metabolic memory. The story of metabolic memory, so clinically we have new evidence, honestly, opening the heart to a better treatment, because the only alternative until now has been, accordingly to the words of Alan Charrington, that in 2005 at the ADA meeting was the first underlining the phenomenon of metabolic memory and recommending the only available solution. Good glucose control should be started as early as possible to delay or prevent serious diabetes-related complications. So, this is my message, my main message, but I want to add 2-3 more evidence which are needed to understand the complete scenario of metabolic memory today. First of all, what is the target of A1C? 7%? No. We have reported, published in Diabetes, that if you look at the people having an A1C between 5.7 and less than 7%, they in any case have an increase of 20% for complications. Do not forget that 7% was settled at cutoff according to the data of the ACCORD and the other trials. But the evidence is there that if you want to avoid any kind of complications using the glycemic control, adopting the glycemic control as a strategy, you must be very close to the normal level. First. Second, not only high constant glucose is inducing the metabolic memory. If you go up and down, and you know that today the story of glucose variability is increasing in terms of interest, also the glucose variability can induce the metabolic memory, so you have to somehow to avoid also glucose variability in order to improve the prognosis for the metabolic memory. And today, when it's so cool, the concept of treating obesity, no? We have another problem. In this wonderful study published in Nature very recently, it has been demonstrated that the adipocytes are developing a metabolic memory for the weight loss, meaning you reduce the weight, but for the cells, this is not enough. The cells want to be back. They want to regain weight. And this explains largely why people losing weight, when they stop all the treatment or the diet, or they think to start to be back to the normal life, unfortunately, this does not work very often, and they regain weight. Because the stimulus coming from adipocytes is so strong, because they want to regain weight. So we cannot just consider our patients guilty because they regain weight, but somehow it's not easy as we were supposing. And finally, body weight variability is also a risk factor for cardiovascular disease. So we have to take in account that this up and down produced by the hungriness of the adipocyte is also important as a risk factor for cardiovascular disease. And finally, there is a metabolic memory for almost all risk factors. These are the long-term follow-up of the STINO study, where the people who were treated from the beginning intensively, for several risk factors control, still have an advantage after years for developing cardiovascular risk. So at the end, what is the final message? The final message is that early strict intervention in any case on body weight, on glycemic control, risk factors control is really mandatory, but we have the hope that GLP-1 and SGLT2 can help in the case we are not able to better control all these risk factors. Thank you very much for your attention.
Professor Antonio, for this very elegant talk. I just want to ask about the lipid memory. You just mentioned about the hyperglycemic memory and its effect on diabetic complications. And you illustrate how the antioxidant effect can delay this complication. Is there any studies you did regarding the lipid memory, which may have an implication on the cardiovascular complication of diabetes?
No, the story of the antioxidant is very complicated because no one antioxidant in vivo, you see, in the vitro and in animals, they work very well. Also, we use to select a specific source of free radicals to demonstrate that mitochondria and not other sources were important for free radical overgeneration. The problem in vivo is that you can do something with the natural antioxidant, meaning in the food, because in the food you have a mix of different antioxidants. When you start to give supplements, it's not the same, because the antioxidant, I try to make short a very long story. they work in the chain, protecting each other. If you just give one, the risk is to have a pro-oxidant action instead of antioxidant action. So the short answer is antioxidants do not work on this. You have the effect of good food, Mediterranean diet, and so on. So this is the way to approach this.
Thank you.
Antonio, if I can ask a question, you've very much illustrated the importance to get this memory is early and sustained glycemic control. Why is it so difficult for us to achieve this? What are the main challenges to achieve good sustained glycemic control?
Doing your job in the best way, not only, but you need a good patient. Meaning that only this alliance, because you are a good doctor, you prescribe the right therapy, but the patient has to follow the therapy, particularly also the diet, and this has to last for all the life. Trust me, it's not easy. It's more easy to prescribe than to be a patient. But probably the education is to have this alliance, which is the only way to get an improvement and in long term of glycemic as well as other risk factors.
Any questions, Professor Antonio? تفضل حضرتك.
Thank you, Professor CERILLO. This is a wonderful lecture, and I appreciate all your hard work in making this something that we use in clinical practice. My question to you is this. Your studies were exquisite in using SGLT2 to prevent oxidative stress. Have you or anyone else looked at the same result with GLP-1?
We have in vitro studies. We publish in vitro. Unfortunately, when we used the database of Italy, the situation was that at that time GLP-1 also was not widely used. And so we did not have enough number of patients, while the Chinese, they had, and then they were able to show also for GLP-1. So we have published the evidence in vitro that unfortunately we were unable to confirm in vivo for the reason I shared with you, but in the Chinese colleagues, they had enough number to demonstrate this.
Thank you.
Thank you very much for your talk, and the illustration is very wonderful. You spoke about good diet. Did you find the modified food versus normal food make any difference? And especially when I speak about modified food, I'm speaking about wheat.
Sorry, I didn't get the question. Maybe if you would speak
okay.
not in the, no, I don't know, by better, okay.
Is it much better now? Can you hear me?
Let's try.
Can you hear me?
Yeah.
Okay. You speak about good food, and it's modified food versus normal food make a difference. And when I speak about modified food, I speak about wheat. Any explanation? Because I found some patients when they change to rye food instead of wheat, they get much more glycemic control. I don't know.
Honestly, I don't know.
Thanks.
It's an interesting new opportunity for research, but also I don't know data about this. Probably, you see, and then I close. What happens in medicine is that the different fields very often are not talking each other. When you see something in one field, then you are surprised that maybe you have an idea very close that in another field has been already tested, and vice versa. So what will be very important is to have an overlook all what exists and to have a cooperation with different skills. This is the only way, probably.
Thank you very much.
Okay, sir, thank you very much.